Hi, this is Alan again. We're going to be talking about another one of the hazards. We've already done O2 toxicity, O2-induced hypoventilation, ROP, retinopathy of prematurity, and retrolental fibroplasia. And now the last one of the four types of hazards that can occur when administering oxygen is absorption atelectasis. This one to me is one of the easier ones to understand. Basically, when you start giving FiO2s at 50% or more to patients who are breathing very shallow tidal volumes, very low tidal volumes, they might be sedated, those patients are at great risk for this absorption atelectasis because when we give this high partial pressure of oxygen, FiO2, it washes the nitrogen out, which is the most abundant gas in the lung and also in the blood. We're looking specifically at the alveoli. Well, it washes that nitrogen out, and that was helping keep the alveoli open. Well, all that's left is the oxygen in the alveoli, but when the blood perfuses along the lung, the oxygen that was in the alveoli diffuses across, attaches to the hemoglobin, dissolves in the plasma, and that alveoli now collapses. If we have a lot of those alveoli collapse, we have atelectasis. We have enough of those areas become atelectic, we have a VQ mismatch. We have a decrease in ventilation even though we have plenty of perfusion. So beware. If your patient is sedated, if your patient's breathing small tidal volumes, be careful of how much FiO2 you are giving your patient. Don't always look at the saturation because the saturation of 100% is not always the clear indication that you're doing a good job. You as a respiratory therapist need to be looking at the PaO2 and getting that PaO2 to be acceptable with the least amount of oxygen to complete the job. Again, this was absorption atelectasis, talking about how the alveoli collapses when you give FiO2s greater than 50% over a short period of time. Thank you.